Okay, now we're going to look at two disorders that are actually opposite disorders because it's an imbalance of one hormone, antidiuretic hormone. And if you remember, antidiuretic hormone is one of the two hormones that help regulate water balance in the system, with the other one being aldosterone. So ADH, normally secreted from the posterior pituitary, acts on the renal tubule, actually changing the permeability of the renal tubule. Therefore, water is what's exchanged, not sodium plus water as with aldosterone. And that's an important concept as we move forward and see what happens as a result. So let's look at diabetes insipidus. So diabetes insipidus is a hyposecretion, or too little ADH secreted from the posterior pituitary. What kinds of things could cause that? Well, traumatic brain injury or anything that could apply a mechanical pressure to the output of the posterior pituitary. Certain drugs could do that. There's something called nephrogenic diabetes insipidus, means the problem is actually with the renal tubule receiving that hormone. Symptoms of profound dehydration eventually. So that's part of your assessment, is looking for those, certainly in addition to copious urine output, other signs of dehydration. And what is interesting is that, again, what is left in the vascular space, because water is what's leaving it, is this serum sodium going up beyond that normal level of 145. And in addition to the serum sodium, we're going to look at a very dilute urine-specific gravity, because what the patient is putting out is really almost pure water with just very, very little solute, a urine-specific gravity of less than 1.005. Serious complications, again, is a shock state, a hypovolemic shock state. What do we do about it? Well, the best thing to do is always treat the underlying cause of it. But in the meantime, we don't want the patient to go into a hypovolemic shock. We replace our antidiuretic hormone. There's synthetic ADH, which is in the form of desmopressin acetate. There is vasopressin, which is also a form of ADH. But remember, vasopressin is also a vasopressor drug. So it could result in myocardial ischemia, ischemia of other organs if it's not given to the right candidate for this vasopressor. And definitely fluid repletion. Let's look at the opposite problems. The opposite problem of too little antidiuretic hormone is when antidiuretic hormone is hypersecreted. So what kinds of conditions would hypersecrete antidiuretic hormone? Certainly if there is a tumor on the posterior pituitary, that is going to hypersecrete what is normally secreted, or the amount that is normally secreted. Also, mechanical pressure on the posterior pituitary could result. Something called old cell carcinoma of the lung results in a chemical that the system reads as ADH and could result in SIADH. Certain medications could also result in SIADH. So what happens in SIADH is that you have too much anti-diuretic hormone. It's not diuresing. So that fluid, that water really, is just being reabsorbed in the vascular space. You don't have a lot of urine output, if you have any at all. If you have some, it's very concentrated with a specific gravity greater than what we know to be normal, so greater than 1.030. Dangerous aspect of SIADH is what is called a dilutional hyponatremia. What does that mean? It means that because it's water being reabsorbed into the vascular space, the serum sodium is being diluted lower than normal, way lower than normal, dangerously low for the neurologic system. So seizures, coma, death could result. So certainly in treatment of it, it's addressing that serum sodium level. And how do we do that? Very dangerous cases, when the serum sodium is really, really dangerously low, we can replete with 3% sodium chloride. Has to be given very slowly. Serum sodium has to be corrected over hours. You could give vasopressin antagonists, which help excrete urine, and the serum sodium is not as much modified. Certainly loop diuretic approach, giving Lasix, could also help address the problem. So don't ever correct electrolyte imbalances quickly, but certainly until this underlying cause is addressed, you have to address that serum sodium.